Do you think AI has the potential to replace the clinicians and the physicians?
Where artificial intelligence is likely going to play a big role is making us better doctors.
Welcome to this edition of Science Talks. We have with us Dr. Srinivas Sadda, the premier in artificial intelligence in ophthalmology. Dr. Sadda, we are very glad to have you for this edition of Science Talks. We'll be talking a lot of points about the role of artificial intelligence in healthcare and especially in ophthalmology. So let me start with this first question. With more than 3,000 publications coming in ophthalmology with artificial intelligence, do you think AI has the potential to replace the clinicians and the physicians?
Well, Dr. Ramesh, first of all, it's really great to join you. And that's a great question because it's a question that often comes up. And I think our thinking about it has evolved as we've gotten a chance to see where artificial intelligence in medicine is going. And I think the answer, as best we can tell now, is that I don't think it's going to replace physicians per se. I think there's always an important role for physicians because it's not just about making a diagnosis, it's also about communicating with the patient and the like. But I think where artificial intelligence is likely going to play a big role is making us better doctors, making healthcare more available. I think those are two potential big benefits. So I view them as being assistive tools for physicians rather than replacing them.
Fantastic. So the other question which we have is that do you think artificial intelligence would have an important role to help people who are in the rural population or in places where the medical assistance is not very easily available, and that could be a way by which they can have an easier checkup and then come to the main centers for examination?
Without a doubt. I think as when I mentioned that I think it's going to make us more available to our patients, that's one of the things I mean is that we'll be able to deploy artificial intelligence in screening solutions, automated screening to be able to detect disease earlier, get patients in. And also, I think we'll be able to empower patients. I think that one of the things to look forward to in this next decade will be the rise of home-based diagnostics or personal diagnostics, where people will be able to take in some measure control of their own healthcare. They'll have, we already have tools. For example, our smart watches can measure our oxygenation. We expect that they'll be measuring blood sugar and other parameters. And we can do something similar with the eye. You can take a picture of your eye, obviously, with your smartphone, and potentially have that analysis done. So I think we'll see an increase, a proliferation of smart tools, hardware tools, married with artificial intelligence to allow this type of screening to occur. Maybe initial assessment at the home, and then maybe an additional layer or more sophisticated screening at a nearby center. And so that's where I see a more streamlined system, which I think is going to be essential, not only to get to the rural areas, but also to deal with the fact that we have a growing population that we need to be able to take care of.
Dr. Sadda, we also want to ask you whether artificial intelligence, since it's growing very fast, very rapidly these days, what would be its role in healthcare currently?
Well, currently, at least I can speak most specifically about the situation in the United States, but I think it's expanding more broadly. But we already have, obviously, the deployment of multiple artificial intelligence tools for diabetic retinopathy telescreening. So basically, a fundus camera can be used to take images of a patient's eye at their primary care doctor's office or some similar setting, and then the images are sent to the cloud, analyzed, and an indication is given whether the patient needs to come promptly or be referred properly to the ophthalmologist, or whether they can just come back again on a more routine basis. So that's already deployed, not only deployed in the US, but deployed in many countries around the world. In addition, we also see, at least in the US, home OCT married to artificial intelligence for automated detection of fluid and disease activity. That's already made its way there. And then there are a whole portfolio of tools that one can access through imaging devices such as OCT, where you could access third-party tools and do potential analyses. Not all of these, of course, have been FDA cleared. Many of them have been CE marked, and many of them are available in different countries around the world. So those are deployments that already exist. And obviously, we're going to see screening expand beyond diabetic retinopathy to other diseases, glaucoma, myopia, ROP being some of the big ones. So those I think we can expect in the very near future to become more broadly available.
With artificial intelligence, with a retina examination, have we reached the stage right now where you can actually predict a systemic disease with just a regular fundus screening or a retinal screening?
Yeah, I'm glad you brought that up because that is another important application. We know from early work that you potentially could take a fundus image and make some computation of someone's age, within a few years, or even, as it turns out, even their sex, but also something about their cardiovascular disease status and maybe their neurologic disease status, maybe potentially, for example, identifying Parkinson's or Alzheimer's disease and the like from different types of fundus imaging. For those, in large part OCT, but maybe other fundus imaging as well. And so that is very interesting because we're learning new things about the retina as a result, because sometimes those are things we could not observe ourselves. So that's a whole different aspect of artificial intelligence in allowing us to see information that we could not otherwise perceive, that was still encoded in the images. So that's an exciting advance, and I think it underscores the fact that we as ophthalmologists in the future may be called into an important role for the systemic disease diagnosis, in particular cardiovascular disease, because we see the retinal vasculature, which obviously gives us some insight into the vasculature of the rest of the body, but also central nervous system disease, because of course the retina is an extension of the central nervous system.
And in the United States, do you have any regulatory bodies which decide the rules, regulations, and the ethics related to artificial intelligence and its applicability in your clinic?
Yeah, this is a rapidly evolving field. And yes, I mean, it took a while for example, the US FDA to come to some policy decisions when we're talking about artificial intelligence, because they had to become educated on what are the potential pitfalls. And so that's actually created some interesting but important challenges. For example, at present, the regulatory bodies in the United States, they require that any AI algorithm that's going to be approved, that it be evaluated on prospectively collected data. The rationale being that if you use retrospective data, potentially the algorithm may have been exposed to that data before, and that essentially would provide some advantage to the algorithm, which may not actually tell us how it's really performing. So the agency requires a prospective study. That creates certain challenges because that makes development of AI algorithms more expensive. Prospective studies are expensive. But that is the trade-off. That is the challenge that we face. But I think it's necessary until we are able to better understand how these algorithms do. One last point I want to add about that, though, Dr. Ramesh, is that even if you have regulatory approval of an algorithm, you have to keep in mind that these algorithms are developed for only they're only as good as the training set that went into them. And the other thing that from an ethics standpoint that the agencies are starting to require is to make sure that the training data that goes in is diverse. It can really apply to a broad spectrum of the population, which I think is very important. But still, you have to test, I think, any algorithm out in your own environment because you just don't know how it might perform if there are variations that it hasn't been exposed to.
And since you are being the editor-in-chief of one of the international journals, how do you see AI being used by your authors in publications?
Yeah, that's a great question. And many journals now, we've come up with policies that people have asked, can I, if I have a ChatGPT or some other large language model write my paper, can they be or contribute significantly in terms of, maybe you give it some concept and it fashions the paper for you like a science writer would. Should it be an author? And people have gone through this and say, no, it doesn't meet the international criteria for authorship. So we don't accept that. And generally, we discourage the use of ChatGPT, or want to limit or curtail its use. But when it is used, because people might use that to maybe improve the grammar or something else of that sort, seems pretty reasonable. It needs to be indicated in a section of the manuscript to explain what was used, exactly what it was used for, etc. So I think that's probably the best we can do right now. I think a bigger challenge for the future will be the possibility that people can create synthetic data or other types of things, synthetic images, using AI, these sort of deep fakes that people talk about. And that's something that as journal editors and the like, we have to become more sophisticated and arm ourselves with our own tools to detect those kinds of potential missteps that people may take.
Dr. Sadda, it was really nice having you.
Thanks very much.
For this edition
really
of Science
enjoyed
Talks.
the discussion.
Thank you so much.
Thank you.